At the outset, I would like to thank Dr. Srinivas for giving me this opportunity to talk about first attack of vertigo, how to rule in or out stroke in first 5 minutes. Dr. Mohammed sir had covered most of the points, so mostly it will be a revision. So the main purpose of my talk is to avoid misdiagnosis in a case of acute vestibular syndrome. So before we venture into this topic, let me tell you what acute vestibular syndrome is. It is a syndrome that comprises of persisting vertigo for more than 24 hours with a spontaneous nystagmus, postural instability, and neurovegetative symptoms like nausea and vomiting. And in a typical emergency department, about 2.5% of cases could be cases of AVS. And many observational studies have pointed out that 25% of posterior fossa stroke can present as AVS. And in 38% of patients, vertigo could be the sole presenting symptom. So we must differentiate these central causes from peripheral causes like vestibular neuronitis, which are very common. Why differentiate? Because the line of management is going to differ for both, and if you are going to allow ischemic stroke, if we are going to allow the infarcts to expand, it's going to increase the intracranial pressure and cause a brainstem herniation, which is going to be life-threatening. So mostly I'll be talking about the pica stroke and the ICA stroke. So they supply overlapping territories in the brainstem and the cerebellum. We must remember that the anterior inferior cerebellar artery has blood supply to the inner ear. I'll be discussing the clinical significance later. So here I have given the symptoms and signs with which these types of strokes can present. I'm going to run through these slides. Most of the symptoms are overlapping except symptoms like tinnitus and hearing loss. They are common in ICA infarct. So these are the other symptoms. Most central causes of acute vestibular syndrome are ischemic. The other uncommon causes are hemorrhagic. Cases of multiple sclerosis can present as AVS. Some more uncommon causes are labyrinthine stroke, herpes zoster, oticus, brainstem encephalopathy, brainstem encephalitis, and so on. Just like in any other case, a careful focused history and a proper bedside examination will point to diagnosis in most of these patients. So start with a good history, go to the examination. Examination of gait is very important. Do a quick ear, nose, throat examination. Pay attention to tuning fork test where you assess the 8th cranial nerve. Look for facial nerve function. Look for sensation over the face with special attention to pain and temperature. And look for ptosis, meiosis, and anhidrosis. Then comes the indispensable test, the Hints examination. It stands for the head impulse test, Nystagmus Q deviation. Then don't forget to elicit the cerebellar signs, especially the signs of dysmetria. Look for this finger nose test, the dysdiadochokinesis. Look for exaggerated knee jerks. Look for the tone of the muscles. And how do I play the video? Oh, sorry, I cannot see it here. So this is a patient, a 60-year-old lady whom I had presented with dysphagia. She had this frank dysdiadochokinesis. So I just wanted to show this to you. Then you elicit the Romberg sign. Then do a cranial nerve examination with specific attention to 3rd, 6th, 9th, and 10th cranial nerve. Then also do a cold caloric test. So details in history, what we should be looking at. So the most important is the clinical course of the disease. Has the dizziness been gradual to start with, and has it progressed to attain the present intensity, or has it been intense from the beginning itself? If it is the former, it is more in favor of a peripheral cause. If it is the latter, it is more in favor of a central cause. Look for the disproportionality of symptoms. Is the patient's vertigo proportionate to the postural instability? Is it disproportionate? If it is the latter, in a cerebellar stroke, the patient will not be able to stand even with the eyes open. It is very difficult for them. Look for vascular risk factors in the patient. Look for focal neurological signs. But mind you, they can be absent in about 2/3 of the patients. What are the focal neurological signs? Hemisensory loss, internuclear ophthalmoplegia, gaze palsy. Then you have hemiparesis, etc. Then look for the deadly Ds. They are diplopia, dysmetria, dysarthria, dysphagia, and dysphonia. Also, don't forget to elicit the drug history. Look for immunocompromised state. Look for history of ear infections. Look for history of ear surgeries, and so on. This is a slide to demonstrate cerebellar ataxia.
The ataxia gait, the patient has difficulty narrowing the station, maintaining balance. So typically they'll have a wide stance, is trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior-posterior type of tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, and I then try to walk tandem, then I'm going to have...
So this is just to demonstrate the ataxia of cerebellar pathology. And these patients also can have a typical truncal ataxia. So how to bring it out? You ask the patient to sit on a couch and ask them to fold their arms across the shoulders. They will be unable to do so because patients with truncal ataxia cannot do this. Now, having looked at the history, what are the safe to go features when you can dismiss a case of AVS as a more benign pathology? When the patient doesn't have any excessive vomiting or a gait disorder, when the patient doesn't have any sustained neck pain, no auditory or neurological symptoms, if they are able to stand and walk unassisted even if unsteady, no papilledema, Horner's or cranial nerve signs, no dangerous D symptoms, no sustained neck pain, no fluctuating hearing loss or tinnitus with more attacks, that goes in favor of a Meniere's disease, no history of migraine headaches with most attacks, that goes in favor of a vestibular migraine. Now, coming to the bedside examination, the HINS examination, as I told you, it is one of the most effective indicators. It is more effective in even ruling out a stroke than a diffusion weighted MRI. We have this acronym called the INFARCT. It was already mentioned previously, but I'll again stress upon that because it's a pointer to a central cause. So, INFARCT stands for impulse normal, fast phase of nystagmus alternating, and refixation on cover test. Send him on home is acronym for benign cause of acute vestibular syndrome, straight eyes, head impulse misses, one-way nystagmus, healthy aortic and mastoid examination. Now coming to the nystagmus, how to differentiate a peripheral from a central nystagmus. A peripheral nystagmus will follow Alexander's law, and this is actually nystagmus examination. I'm going to skip that. So this is a patient who had a typical peripheral nystagmus. So this is a video of a patient with a right vestibular neuritis. You can see the typical peripheral nystagmus with the fast phase beating towards the left. And when you observe, when the patient looks towards the left, see what is happening. So what I wanted to highlight in this is when the patient starts looking towards the left, the nystagmus will become more intense. So this peripheral nystagmus will follow Alexander's law. So that's what, see now you can see the nystagmus becoming more intense. So this is what I wanted to highlight. And another quality of this nystagmus is it suppresses with fixation. This is another patient with vestibular neuronitis. So the nystagmus becomes less intense with fixation. The same patient, after removal of fixation, the nystagmus gets intensified. Now, coming to gaze-evoked nystagmus, it is a red flag. It is more a pointer of a central etiology. It is nothing but a direction-changing horizontal nystagmus in the lateral gaze, which means that when the patient looks towards the left, the nystagmus will beat towards the left, and the patient looks towards the right, the nystagmus starts beating towards the right. So, it is due to dysfunction in gaze-holding structures in the cerebellum. This is a patient who had a central nystagmus. This is not a typical gaze-evoked nystagmus. She had a Arnold-Chiari malformation. Why I wanted to put this video is to highlight the direction-changing nature of the central nystagmus, which is non-fatigable and also doesn't get suppressed with fixation. Now it has changed the direction. Initially it was beating more towards the right. Now it has started beating towards the left. Now the head impulse test is one of the best indicators of stroke, and it is a test to assess the integrity of the vestibulo-ocular reflex pathway. We know that the pica stroke, the posterior inferior cerebellar stroke, spares the VOR pathway. So in these patients, we will have a normal head impulse test. But in cases of ICA stroke, the ICA artery supplies the inner ear. So if there is going to be a ICA stroke, then the vestibular system and the hearing is going to be affected. So we need to do what is called as HINS plus examination, where you combine the routine tests with a finger rub test. Finger rub test is to assess the hearing. So how to do it, I am not going to talk much about it. So in a normal head impulse test, what happens is the head moves in one direction, the eyes move in the opposite direction to stay fixed on the target. So what happens in an abnormal head impulse test? You get the head moves in one direction, but the eyes also move in the same direction of the head, and then they refixate on the target. So that is when you get your catch-up saccades. So in this patient, she has a right catch-up saccade. Now this is the V-hit test. Why do a V-hit test? Because sometimes the catch-up saccades are hard to see when there is head movement. You can easily see them at the end of the head movement, but during the head movement, it is difficult to see them. So that's why we perform the V-hit. Also, it gives us the VOR gain. So VOR gain will be less in case of a labyrinthine dysfunction. Also, we should remember that in case of a normal VOR in a HIT test, it's a strong indicator of a central localization, but an abnormal VOR is a weaker predictor of a peripheral localization. Next comes skew deviation, again a red flag pointer to central cause of acute vestibular syndrome. So it can be diagnosed by means of the alternate cover test. So you look for vertical ocular misalignment in this test. And this particular deviation is due to right-left imbalance in otolith input to the oculomotor system. So there is a triad of skew deviation, head tilt and ocular counter roll. It is called a ocular tilt reaction. So we can see this particular patient with the right Wallenberg syndrome has a typical ocular tilt reaction towards the ipsiversive side, that is the right side. It can be contraversive in pontomesencephalic infarcts. So this is a table to show the common oculomotor anomalies in patients with Wallenberg syndrome. The most common were gaze-evoked nystagmus, lateropulsion of closed eyes, spontaneous nystagmus, saccadic pursuit, skew deviation and ocular tilt response. These were the uncommon ones: saccade dysmetria, central positional nystagmus and horizontal gaze paresis. Romberg's test is not a test for cerebellar function as it is most commonly misconstrued. So it tests the body's sense of positioning by assessing the vision, the somatosensory system and the vestibular system. So in Romberg's test, if the patient is deprived of the vision, if they are going to sway to one side, it means the vestibular system of that particular side is weak. This is a tandem Romberg's test in a patient who had vestibular neuronitis. You can see that she puts one foot in front of the other and she drifts towards the left side. So this is a patient who had a left vestibular neuronitis.
I am here, don't bother.
She is saying to the left side. Close
your eyes.
Left.
Drifting towards the left. And you have the Unterberger test where the patient is asked to march on the same spot for about 30 seconds. And similar to the Romberg's test, a sway or a tilt of the body to the affected side is expected in vestibular lesions. Now, I have written this case discussion here to point to a typical history of a patient with a vestibular neuronitis. So, in this box, I have written the tests that help me more in diagnosing this patient. I would like to highlight the value of the cold caloric test. In a patient with vestibular neuronitis, the cold caloric test will remain unaltered, that is, it will not give any response on the affected side. So, you are going to have the spontaneous nystagmus without any alteration on the affected side. If you syringe on the unaffected side, then there is going to be an attenuation of the spontaneous nystagmus. Not going to talk about vestibular neuronitis in detail. Let me show you a few other oculomotor abnormalities that we can observe in central lesions. This is again not a patient with stroke, but this was a patient who had a progressive supranuclear palsy. So this I had kept to highlight the saccadic smooth pursuit. So this we cannot rely upon in acute cases when there is strong nystagmus. Now here is a table to point out the clinical findings as predictors of stroke versus vestibular neuronitis in patients presenting with acute vestibular syndrome. So concentrate on the ones which I am pointing at. So dizziness of gradual onset, more a predictor of neuritis, strength of predictor is strong. Multiple prodromal episodes of dizziness, more in favor of a stroke again, and the strength of predictor is strong. History of craniocervical pain, again predictor of stroke, and the strength of evidence is, the strength of the predictor is moderate. And if you are going to have neurological symptoms, disproportionate symptoms of gait, then again predictor of stroke. Age more than 50 years and other vascular risk factors are again in favor of a stroke. Now, this is the VOR cancellation test. This is a test for cerebellar function. Cerebellum functions to cancel the VOR. So when you ask the patient to fix his or gaze on a target, and when you move the head and the hand together, the gaze should not drift away from the thumb. If this drifts, then it is a pointer of a cerebellar pathology. So he is observing for drifting away of the eyes. When to consider MRI in these patients? When the patients have severe vertigo or imbalance persisting beyond 72 hours, in the presence of focal neurological signs, then in the presence of a normal head impulse test, and patients with risk factors like diabetes, hypertension, atrial fibrillation, etc. What are the main causes for misdiagnosis? The frontline misdiagnosis rate is about 34%. So it is mainly because of inappropriate reliance on CT scans, because CT scans have very low sensitivity, only about 16%. Absence of focal neurological signs. I told you they can be absent in about 2/3 patients. And dismissing the young age as an age group that is not at risk for stroke. That is not correct, because a young age with history of trauma, they are more susceptible to things like vertebral artery dissection. So we must keep this in mind. And doing provocative tests in an acute vestibular syndrome is going to exaggerate the symptoms and is going to mislead us into diagnosing more benign causes like BPPV. So the take-home message will be, it is very important to treat the cause rather than the effect, and a good history will be a pointer to diagnosis in a majority of cases. And it is very important to avoid vestibular sedatives prior to our investigations. And common things are always common. Uncommon cases we should always discuss with our seniors, and that will help us in getting a good picture. I thank you all for your patient listening.